Assalamu alaikum. Now, now I would like to discuss about blunt chest trauma. If a patient comes with blunt chest trauma, first of all, look at his stability. If the patient is hemodynamically stable, or if the patient is hemodynamically unstable. If the patient is hemodynamically unstable, that means hypotension, tachycardia, tachypnea, resuscitation and evaluation, do a fast chest x-ray, ECG, with or without stabilizing intervention, chest tube if indicated. If hemodynamic stability achieved or maintained, if hemodynamic stability achieved or maintained, no, do thoracotomy. Take the patient to OR for thoracotomy. If the patient is hemodynamically stable, high risk mechanism or serious injury on examination, if yes, if high risk mechanism or serious injury on examination, then again you do a fast chest x-ray, ECG with or without stabilizing intervention like chest tube if indicated. If hemodynamic stability achieved, if hemodynamic stability is not achieved, take the patient to OR for thoracotomy. If high risk mechanism, if no high risk mechanism, abnormal findings, evaluation, chest x-ray, ECG, no possible discharge or observation. If yes, additional chest CT can be done. If additional chest CT shows there is complication, there is problem, yes, hemodynamic stability achieved or maintained, no, again thoracotomy. So this is all about blunt chest trauma. So hemodynamically unstable patient, e-fast ECG and chest X-ray with or without stabilizing intervention like chest tube. Okay, hemothorax. After blunt chest trauma, the most important topic regarding this is hemothorax. What is the underlying cause of hemorrhagic shock in a patient with decreased breath sound, tracheal deviation, dullness to percussion? Decreased breath sound, tracheal deviation, dullness to percussion, it is hemothorax. Each hemothorax is capable of holding 50% of the circulating blood volume. Very, very, very high yield. Life-threatening hemoptysis jeopardize airway, severe hypoxemia, hemodynamic instability, generally occurs bleeding rate more than 100 ml per hour. It is managed by securing the airway, bleeding placing the patient's bleeding bad lung if lateralization is known down to prevent spillover into the good lung, and obtaining urgent hemostatic control via bronchoscopy, embolization and surgery. What is the treatment of hemothorax? Chest tube insertion, thoracostomy. Thoracotomy if more than 1500 ml blood is lost or more than 200 ml of blood is 200 ml per hour for more than 2 hours of blood is lost, or continuous need for transfusion to maintain hemodynamic stability. So first, chest tube insertion, thoracotomy for massive fluid loss, more than 1500 ml of fluid loss or more than 200 ml of blood per hour for more than 2 hours, and continuous need a transfusion to maintain hemodynamic stability. A hemothorax, however small, must always be drained because blood in the pleural cavity will clot if not evacuated, resulting in a trapped lung or an empyema. Tube thoracostomy, chest tube insertion, involves placing a hollow plastic tube where between the fourth and the fifth intercostal space and the mid-axillary line into the chest. Fourth and fifth intercostal space and mid-axillary line into the chest to decompress a hemothorax and or pneumothorax. This is fracture, rib puncturing, lung parenchyma, lung fracture, rib puncturing, lung parenchyma. There is bleeding. So this is the hemothorax, rib fracture with hemothorax. May result from injuries to large aorta, hilar vessel, and small trachea or small intrathoracic structure or intercostal bleeding, lung parenchyma. Now, tracheobronchial injury, TBI. Tracheobronchial injury. Tracheobronchial injury clinical feature is dyspnea, subcutaneous emphysema, very high yield, subcutaneous emphysema, treatment resistance pneumothorax, not tension pneumothorax. There may be pneumomediastinum here in the mediastinum, Hamannsheim, pneumomediastinum Hamannsheim. Diagnostic is chest X-ray here in the surrounding soft tissue. Bronchoscopy show visualization of the lung. Tracheobronchial injury versus tension pneumothorax (TBI) does not feature midline shift and distended neck vein, very high yield. It does not feature midline shift and distended neck vein and complication chylothorax, chylopericardium, and chylomediastinum, mostly surgical repair. Persistent pneumothorax, significant air leak following chest tube placement, significant air leak following chest tube placement in a patient with blunt chest trauma suggests tracheobronchial rupture. Often findings include pneumomediastinum or subcutaneous emphysema. Definitive TBI, BI bronchoscopy and surgical repair. TBI bronchoscopy, TBI diagnosis via bronchoscopy and surgical repair. Always remember the GEST thing because there is plenty of information and it is unable to remember in the exam. So click point should be remembered for exam. Now the last topic, pulmonary contusion, very high. It is very tough to diagnose a case of pulmonary contusion. Present less than 24 hours after blunt thoracic trauma. It present less than 24 hours after blunt thoracic trauma. There may be tachypnea, tachycardia, and hypoxia. There may be tachypnea, tachycardia, and hypoxia. Diagnosis RALS or decreased breath sound. CT scan is more sensitive. CT scan is more sensitive and chest X-ray with patchy alveolar infiltrate not restricted by anatomical border. Pain control, pulmonary hygiene, and supplemental pulmonary hygiene incentive spirometry, chest PT, and supplemental oxygen and the ventilatory support. So pulmonary contusion PC less than 24 hours after PTA, blunt thoracic trauma. There is tachycardia, tachypnea, pain control, pulmonary hygiene, and the supplemental oxygen and ventilator support. Look at the picture of this pulmonary condition. There is irregular non-lobular infiltrate. On chest CT. Pulmonary contusion may present with non-cardiogenic pulmonary edema. Non initial X-ray may be negative. The trauma can produce leaky capillaries. The trauma can produce leaky capillaries leading to dyspnea and a non-cardiogenic pulmonary edema with a normal non-cardiogenic pulmonary edema with normal pulmonary capillary wedge pressure. So that is all about pulmonary contusion, tracheobronchial injury, TBI, tracheohemothorax, and blunt thoracic injury. Okay, blunt chest trauma. In the next section, I will discuss about some questions regarding blunt chest trauma, hemothorax, tracheobronchial injury, and pulmonary contusion. Hope you enjoyed.